Hello, I'm Joan Hughes, the CEO of Carers Australia. It gives me great pleasure to introduce this program, Caring for Carers, Depression and Anxiety and the Impact of Caring. This program is a joint initiative between the Rural Health Education Foundation and Beyond Blue, the National Depression Initiative. It's well known that carers make an enormous contribution to their home, to their family, to community and to society at large. While caring can bring many rewards to individuals and families, we now know through research that caring can place enormous strain on the health and well-being of family carers across this nation. This broadcast recognises the important role that health professionals have in asking the carer how they are feeling or how they are coping. It is very easy for the family carer to put their own health needs aside, and sometimes that becomes secondary because they're so concerned about the person they are caring and supporting. Often signs of depression with family carers go unrecognised, and health providers often put it down to life stages or other stresses of everyday life. It is absolutely vital that health professionals address the mental health needs of carers. Caring must be seen as a shared responsibility within families, within community and across systems of care. We need to make sure that we're all working towards maintaining and enhancing families' own health and well-being.
Thanks to Joan. Hello, I'm Norman Swan. Welcome to this programme on Caring for Carers, Anxiety and Depression and its Impact on Caring. Carers, as you all know, provide unpaid care and support to family members and friends who have a disability, mental illness, chronic condition, terminal illness or are frail aged. And we couldn't live without them. Caring for a family member can be both rewarding and demanding. But the overwhelming, often responsibilities of being a carer can have a significant impact on a person's mental health. Tonight we're going to be discussing the importance of addressing the mental health needs of carers and the particular challenges of caring for someone who has mental health issues. As always, you'll find a number of useful resources available on the Rural Health Education Foundation's website, that's rhef.com.au. But let's meet our panel. Jo Battolini works in Darwin as a social worker. She's also worked in juvenile justice, child protection, Indigenous mental health and in a women's refuge. Welcome.
Good evening.
John McGrath is Deputy Chairman of Beyond Blue, the National Depression Initiative, and has served as a board member since its inception way back in 2000. John has personal experience of being a carer of family members with mental illness. Welcome, John.
Good evening, Norm.
Chris Mitchell is a GP in Lennox Head, New South Wales. He's also the current president of the Royal Australian College of General Practitioners. Welcome, Christopher.
Thank you.
And last but not least is Linda Rosie, who works for the Mental Health Council of Australia on mental health care issues. And Linda is the project manager of the Carer Engagement Project, which surveyed the issues and concerns of mental health carers across Australia. Welcome, Linda, and welcome to you all. John, what's the story with your story as a carer?
Well, as brief as I can be, Norman, for those out there listening tonight, perhaps a touch of reality of what really happens to families. We lived in a farming community in southwest Victoria, and my wife and I had 5 children and grew up in a fairly normal home environment, I think you'd describe it. All seemingly doing well at school and doing well at sport and all those things that families seem to participate in. But our second boy, Shane, who had been a straight A student right throughout his school, hit a bit of a wall in his final year of secondary school when his principal uncharacteristically invited himself to our place for dinner. And what that was all about was he was concerned about Shane's grades and what was happening. And so we had a discussion with Shane about that, and Shane said that he was bored and he didn't find school challenging anymore, those sorts of reasons or excuses. And so I gave him a bit of a dad to son talk, I suppose, and he backed up for a while, but ultimately he finished his HSC that year with a deplorable fail from a straight A student, and he refused to go back to school to have another go, and he then went and undertook a TAFE college course, and we weren't alarmed at that stage because there was no great information available for families. we just thought this young fella, who was a spirited boy right from the time he was born, was starting to stake his claim in the world, doing the sort of things that...
This was a normal adolescence period.
Well, that's how we interpreted it at the time. He was a spirited young fella. He had a lot of spirit. And so he went off doing this, and he done different things. I had a small business at the time. He came and worked for me. He was spotted by an international manager of a large company that wanted to take him to Melbourne to do some training. He subsequently did that. But after a short period of time there, he just up and left. And they had no idea where he was. I ultimately found him. He'd been busy selling up every material possession he had, and he'd made a decision to go to India and help the starving and underprivileged people in India. He felt that that was his call in life. And that raised a few alarm bells for us, but he wanted to do it, and he seemed to be reasonably rational in his description of his want at that time. So we went and bid him goodbye, and he went for a year. But we got a very distressed phone call 11 weeks later, and arranged to get him put on a plane and brought him home, and therein started a roller coaster that a family that has no information is really frustrated and disillusioned with
what was
when
wrong
it
then?
starts. Well, at that stage, we still didn't know. He was certainly behaving uncharacteristically, but there was no symptomology from our point of view with the little knowledge we had, and I think that's the important message here, was the little knowledge we had. But then I received a phone call from his older brother, and he said, "You better come to Melbourne." He said, "Shane's had a serious attempt on his life," and he was in intensive care in the Alfred Hospital, and we went down, and a trainee psychiatric registrar there told us that he thought he had a mental illness, but he wasn't sure. He thought he had. And so he ultimately discharged him. We took him back home, and the roller coaster ride started, and he was ultimately diagnosed with a mental illness. And he battled that for 10 years with varying degrees of success, but at that stage couldn't find a medication that was able to settle him. He was a good-looking young fella, and I often say, I can say that because he took after his mum, didn't take after his dad. And he prided himself on grooming. He loved social life. And so you can understand taking medication that caused him to drool at the corner of the mouth, or shake in the hand, or tremble in the leg, was not a good social engagement technique to have. So he would stop taking the medication. Short period of time, he'd crash again. And so ultimately he had 5 suicide attempts, and on the 16th of April 1993 he was successful in taking his own life. And what a tragic loss of a young life. And you look back today, and I'd like to think if Shane was alive today, we probably might have the medications that might be able to turn his life around. We certainly have more information for us as a family to actually make some more considered earlier interventions and judgments about what sort of treatment and what sort of regime.
And it's obviously been the driver behind you being involved in Beyond Blue. But what were the issues for you and your wife as carers?
The issues were the lack of knowledge. We were given a lot of information when the final diagnosis of his mental illness was portrayed to us, but there was no pathway of care. There was no pathway of management that we could follow. We were given this information and sent on a long journey home, and the long journey home was probably 10 minutes, but it's probably the longest drive of my life, because we had no idea what all this information meant to us, and how we were going to manage it, how we as a family were going to manage it, how we were going to access help, how we were going to find people that might have had a similar experience that could give us some learnings about how they might go about doing it.
Did he want help?
No, he didn't want help. We actually had him sectioned from time to time, had the horrific experience of seeing him carted away in a police van after I'd rang the police. Not the sort of thing any parent wants to have to do, but when other family members' safety are in jeopardy and he's unable to be controlled, they're the sort of decisions that have to be made.
What did it do to you and your wife's well-being?
Look, it destroyed our family. It turned our family upside down. Has an horrendous, as I said, we had 5 children. We had 4 other children in the house. and trying to cope with Shane's behaviour and allow those kids to lead a normal life and study and be part of a family. We're a close family. It was a real roller coaster, and it really damaged relationships. It was an horrific episode, and I would never like to see anybody faced with that again, which is why I think we need to have good messages out there for people, good information. Information is power, and we need people to, the message that I probably might come later as well is that I think we need to be listening to what families are saying, because families are impacted tremendously by this. Shane's sisters and brother have been impacted tremendously by this. His mum and I have been impacted tremendously by this.
Do you think you would have been affected less if you'd had more thoughtful intervention to you as a carer, directed to you as carers?
I think the answer to that, Norman, is yes. I think that's the great void that existed at that time. There was no Beyond Blue website. There was no available information that families could go to. There was no available information for consumers to actually go and find out what it was, how it was presenting in them, and what I can do, what options do I have. They were normally given a treatment, and if they took it, they took it. Just a few days before he died was Easter Sunday, and he was in an horrific state of mind. I'd wrestled with him for 2 hours trying to keep him off the road from throwing himself under a transport. We lived on a main highway, and he just wore me out. He was a strong young fella, and I rang my son-in-law and said, look, you're going to have to come and help me. I just can't handle him anymore. So he came around, and in the interim period, I rang the psych service. Out came two psych professionals and deemed him not fit to be sectioned, and left. Irrespective of what judgment I or my wife or the other kids might have made, they made a decision that he wasn't to be admitted. So we were left with this. In desperation, I rang their local GP, who Easter Sunday was a married man with 3 little kids, and Phil ended up on our doorstep, sat on the back step for, an hour and a half with our son, listened to him, talked to him, and eventually got him to go to hospital with him. Should have been something that should have been done by the professionals, but the GP, which Chris will be very pleased to hear, was just outstanding in terms of the knowledge he had, the understanding he had, but more importantly, the empathy he had. He was prepared to listen.
Chris, do you find that the carer is under the radar for the GP?
That
the carer is under the radar?
No, look, I actually don't. I actually think GPs focus on carers a lot because we have a very long-term relationship with families over time, and the carers are usually our patients as well. So the needs of the carers, I think, is fundamental to holistic care, which is really what GPs are trying to deliver. But we do need to listen to both sides of the story and get an understanding of the needs of both the person with the illness and their carer.
Because, the impact is considerable. The evidence such as there is, although it's not terribly well differentiated between people who are caring for somebody with mental illness versus a physical illness, although it can be, in fact, both. It's a lot of depression and anxiety themselves. It's diminution of their physical well-being, back to smoking, drinking, eating badly, not getting any exercise. We're talking about a high-risk group of people.
Absolutely, and they don't look after them. So they don't look after their mental health. They don't look after their physical health without extra support and without the opportunity to share their concerns. So that's a really important part of caring for people that are sick, making sure that we look after the carers.
Linda, you've been doing workshops with carers around the country, different ages, different groups. What have been your findings?
Well, some of the things that John said quite clearly is the need to be heard. Carers find it remarkably difficult to actually give information that they may have about the person they care for. As they become iller and iller, there seems to be not the facility to be heard about their concerns that could lead to early intervention to prevent a crisis in the mental health. That was really one of the major things that the carers came up with, the need to be heard, that space and time, particularly from the GPs, the first port of call.
What about themselves, identifying the problems for themselves rather than the other person? Because the story is that carers don't identify themselves as carers, they actually identify them more with the person they're looking after, and that's where their total focus is, and they feel self-indulgent or selfish if they talk about themselves.
That's right. In the workshops we did 116, and 2/3 of them were in rural and remote locations. And we came up with 15 findings, and almost half of those are issues to do with the care of the person they care for, not with their own carer issues. It was really like drawing blood from a stone to get them to talk about themselves and how being a carer impacted on them and their lives, and to think about what those implications were. Their focus is primarily on the consumer, not on themselves. So it's very hard to draw them out.
And did you get any sense of, so, I mean, there may well be a lot of logic to that. In other words, if the person they're looking after is looked after better, the stress on them might be better or less.
Absolutely. And that's what they said when we talked about respite care and the possibilities and the options they had there. They just sat there and raised their eyebrows and said, no, what we actually want is better coordinated care for the person we care for. That doesn't necessarily mean medical care.
Now, you saying that coordinated, that's like that's medical speak or bureaucratic speak. What did they say when they said, when you're extracting this to mean coordinated care?
Well, basically there are all sorts of bits and pieces. I mean, local organisations do bits and pieces for carers, for consumers. It's different in each state, it's different in each town. It really is a matter of what's happening locally. But often the people who provide care in those different locations don't know what anyone else does. We'd sometimes go to workshops and you could tell if it was a good one where the service providers actually knew each other well. And some small places, the service providers were shaking hands and introducing themselves. They didn't have that coordinated network of care that the carers really need to find out what's available, how to use it.
You were nodding there, Chris.
Well, I was really interested in fleshing out about the needs for a break and respite, because it seems to me that that is really important. And I guess I'd be interested in why that was a lower order than coordination.
Well, really, the carers issue is to get some help in to care for the person we care for will actually give us the respite, because we don't really need that for ourselves because there's nothing wrong with us. So to provide, to actually tell them that really to look after themselves was a priority and to take respite was very important to recharge the battery.
Did you get any sense, I mean, some people say that looking after somebody with a mental illness is actually harder work, more stressful than looking after somebody with a physical illness.
Yeah, I think
Did that come through?
Yeah, I think, and John really gave us a true example there, the chaos that behaviour can bring forward, and the unpredictability of it, and not knowing what's going to happen in the future. The fear of the future was a major issue that came through too. But that unpredictability, whether or not you could go to work today, all those sorts of things, it was real stress and strain.
And, sorry, Jo, you were going to comment?
I'm just back to John, the stigma that's not just with the person who's got the mental illness, this stigma that's pervading the carer from, it becomes an obstacle to them as well. And I'm wondering, with health professionals, that they're not realising that they're actually joining in on not talking about, that way of operating.
I think that's very true. Again, that was one of the issues that they brought up, was that stigma and discrimination. It leads them into isolation, and the unwillingness to actually mix in the community because friends and family don't understand, and find it difficult to understand, particularly if you have drugs and alcohol involved as well.
And the differentiation here between people with, say, psychosis and people with anxiety and depression, and again, often the two can be mixed.
Yeah, within our workshops we didn't find a differentiation as clearly marked as you might imagine, because even with depression and anxiety you can still have unpredictable, chaotic behaviour, so the carers would have to accommodate that in their lifestyle too.
And
I think Norman, the difference would be in the extremity of it. My experience would be that the unpredictability of psychosis is far more challenging than the unpredictability of a depression or an anxiety. Not to downplay the unpredictability of depression, but the unpredictability and the totally irrational behaviour of someone in psychosis is quite challenging on a daily basis. But to actually get people to talk about that is the challenge, and I think that's what Linda's telling us, is that to actually get people to focus on that, because they're not focused on that. They're not focused on the fact that they're feeling terrible. They're not focused on the fact that their salary has gone down by half because they're spending more time at home. Or they're not focused on it because they're no longer in the local group of card players or whatever it is they might have been doing because they're caring for their loved one. It's very difficult to actually drill down and get them to focus on it. And that's where I think the first introduction of care into a program has got to include the carer so that they're listened to and then engaged through care plans.
One of the things that I find is that particularly carers of people with mental health issues seem to carry a lot more, or feel responsible or carry guilt for the diagnosis in a way that carers for people with other disabilities just don't. Do you find?
Look, that is a fact, and what I mean, I thought we'd come out of the era where families and carers were blamed for mental illness. We went through a terrible era where there was an outright blaming of families for mental illness conditions. I think we moved on a bit from that, but there's still a bit of it there, and I think as a consequence of that, I think families take it on themselves. I think they feel a guilt. They examine themselves about, what if we'd done this differently when they were growing up? What if when they were 10 we hadn't done this? And, there's no worse critic of a person than the individual.
And part of the community stigma is that it's all the parents' fault. If only they'd had a proper upbringing.
That's part of it, but the unpredictability is the other part of it. So the community's a little unsure about how to deal with it, and that's a major challenge that we have to work with as well.
What about in Indigenous communities, Joan?
In Indigenous communities, because you've got the complex issue of poverty on top of it and all the other social issues, you're also dealing with a community that literacy is poor, just around general health, let alone around mental health. And so there's a real need for health professionals to be educating people more about the brain being an organ, similar as an organ when you have diabetes, because there's no shame about diabetes, but clearly there's shame about mental health issues. And so clearly for health professionals to change their language.
So you think stigma's greater in Indigenous communities?
Yes, yeah.
So you've got the double whammy.
Yes. Yeah.
And where you work also is a highly multi-ethnic community. What about other groups, the culturally and linguistically diverse groups, in terms of the approach here? Because some, like Aboriginal communities, and Torres Strait Islander communities, can be very close-knit, family-centred groups.
I think that can be said for other groups, particularly in Darwin, where there's difficulties accessing health services anyway. Not just because of language barriers, but also the medical language and the whole alienating way it is. You go to a mental health service, it's quite alienating. There's nothing healing about it or inviting. So it gives off another message that this is a shameful place to be entering. Families, in many of these groups do want to try to do the best they can with what they can and hope it will pass. And often families can be guilty of saying, just get over it, pull yourself together. And that's the desire of people to want to be happy, But I think there's more of a concern around health professionals that they don't have better ways of engaging people with their cultural context.
What did your workshops tell you about privacy? One hears from carers a lot, probably more so people with psychosis, but also people looking after people with major anxiety and depression, that they can't get information and therefore they're shut out of the process because people fear divulging of personal information.
It was one of the major issues that the carers came up with, the way in which the privacy and confidentiality legislation is interpreted by health professionals. And they saw it as a complete barrier and exclusion. So the things they needed to know about the health and welfare of the person they cared for were actually kept from them, so they couldn't actually do the job as well as they needed to. For example, medication. A lot of the carers don't even know what medication the consumer is on, even though they live in the same household. So they don't know what the side effects are likely to be. They have no knowledge, and without that sort of knowledge, they don't know how to care.
Let's continue this discussion after we've looked at the first case study, because I think the first case study illustrates some of these issues to do with confidentiality. Because this is a filmed case study taken from the Beyond Blue DVD. It's called Carers, Stories of Hope and Recovery. It's available from Beyond Blue. And in it, Paul and Deb Cochran talk about caring for their daughter Jessica.
Jessica was diagnosed with anxiety and depression when she was 12, about 7 years ago. Jessica had always been a great child growing up at school and at home and socially. We'd never really had any problems at all.
She started behaving differently. She was stealing things from people, which was just a real shock to us because she'd been such a good kid. She was telling us lies about things. She was not talking to us anymore, and she used to always tell us everything. And her social groups were changing too. She wasn't mixing with the same kind of kids.
Given that she was going into her teens, of course we did feel early on that this was probably just teenage angst and adolescent behaviour.
The reclusiveness and locking herself away in her room for long hours studying, and the fact that she wasn't relating well with peers, even old friends, was starting to make us feel quite concerned. After talking with her and her refusing to share with us how she felt, we said, well, if you won't talk to us, we're going to have to take you to the school counsellor. So we started with that.
It was discovered very early on that she was severely depressed and fairly suicidal in her thoughts. And so very quickly she was actually referred into an adolescent psych unit.
I think I did go into shock. I just couldn't function, and it took several weeks for me to regain some sense of control over how I was feeling and what was going on in the world.
You go through a roller coaster of emotions, depending on the day and the time. Obviously confusion, distress, despair. It's just a roller coaster, and trying to manage those emotions is very difficult. We were questioning ourselves as to what we'd done wrong, which I think is natural for parents, and also some of the questions from the healthcare professionals to us was what had happened to Jessica in her life, in the family life, that had caused or led to these problems, as in traumatic events. So there was a lot of self-searching going on.
I really did feel I must have done something wrong for my child to go from being happy and healthy to having all these problems.
There was nothing. We'd had a very happy family life, a very stable family life with no issues, no traumas, no dramas to speak of. Nothing to indicate why Jessica would suddenly go down this path of depression and actually to the point where she was suicidal. We were very conscious of the fact that we needed to look after Alex, her sibling, as well. But of course, because there's so much of your time and energy and focus on the sick child, it's natural that the other child's going to be left on the side, so to speak. And so even despite our best intentions, certainly Alex struggled from very early on with what was going on in the family.
Our extended family had a lot of trouble understanding what was going on. They weren't living it every day, and you know, when they did see Jessica previously, she'd been so healthy and normal, they couldn't appreciate that suddenly the wheels had fallen off and she was quite sick.
I think one of the big issues we've had over the 7 years, right from very early on, was the privacy issue and the fact that the information wasn't readily available to us, even as her parents and as her carers.
Privacy laws dictate that at a certain age, parents are no longer required to understand what's going on, and we were only ever told what Jessica was happy for us to hear, and for a long time she didn't want us to know much at all.
We eventually insisted that all the professionals involved in Jessica's care actually got together in the one room at the same time with us. It was a very difficult thing to organise, but we did achieve it, and we found these round table conferences that we had basically once or twice a year were absolutely crucial to make sure that everybody was on the same page. us being present at those meetings as well meant that we were getting information that normally we wouldn't be able to obtain. The realisation that it was an illness separate to Jessica that was the cause of the problem, and it took me a while to get that. And when I did finally get that, it was an absolute revelation, and the situation changed for my relationship with Jessica overnight when I indicated to her that I got the fact that this wasn't you, this was an illness that was driving your behaviour. And things turned around quite quickly once I made that connection.
Paul and Deb Cochrane. Chris, the message is there for you?
Oh, look, I mean, I think the power of that story is very impressive. And the message I get is actually listening to what the carers need and hearing what's really hurting them is very important. But there's a few things there. The involvement of the school counsellor, I think, was an important message and a useful one for GPs to consider. The range of emotions that those carers were feeling. And the issue of privacy and the way it was dealt with through case conferencing, I think, was also a very helpful message. But getting a real shared understanding of what information the carers actually need and what information the patient is absolutely happy to share, I think, is a very important discussion, because privacy is actually quite complex.
What are the issues for you as a GP on a day-by-day basis with privacy?
The issues for me are making sure I've got a clear understanding of what information my patient's happy to share and with who. And that changes actually from time to time, depending on the patient's circumstances.
John, do you think more is made of this than...
Oh, you know, this is one of my hobby horses, Norman. I get pretty excited, sometimes even angry, talking about this, because there's evidence around that if the questions are put the right way, we can get the right answers. And you know, the best example of that was a survey at St Vincent's Hospital in Melbourne through their mental health sector, where they surveyed all of the clients within their service.
So not the carers, the clients. The
clients. And it was a wide-ranging survey, but asked in a way that elicited what they believed was honest, well-intentioned answers. And 86% of the respondents said they wanted their carers involved, which is far less than what happens in real life. And as a carer, I get really, really annoyed that a family...
You mean what happens in real life is lower than the 86%, unless we don't achieve the target?
Far lower. What I mean, I'd suggest probably under 30%. I don't have the figure, but very low. And I think the typical example of that DVD there is that these people had to convene the case conference themselves. Yes. I mean, the system didn't do it. The mental health plan didn't do it. They had to actually convene that themselves to get the answers they wanted. The system's upside down when that has to happen. I mean, why isn't the system accommodating the people? We don't need to know everything as carers. We don't need to know all of the intimate and private details of the person we're caring for. But we do need to know, as Chris mentioned, about the medication. We do need to know about the treatment plan and what's expected, how many times they attend the doctor or how many times they're supposed to do a special activity, and what sort of behaviour is this likely to present? What are the side effects of the medication? Should we be aware of that? We don't need much more information than that. I mean, that's pretty simple, straightforward stuff. It's hardly a breach of privacy. But so many people hide behind it all the time.
So what are you saying, that if the question is framed to the person with the mental illness saying, are you happy for your medications to be discussed? We're not going to go anywhere near, you know, how many girlfriends you've had or etc., whether you've had sexually transmitted diseases. We're only going to talk about these things.
Exactly, and agreement can be reached at a time when the plan's put in place. When the person is reasonably well and a treatment plan is put in place, that's the time that you discuss what you'll convey to the family carer, what you want. But I mean, as a family carer, I resent being given the responsibility of caring for my loved one when they're not in hospital, and I have no say in what sort of treatment they get. When they send them home in a taxi at 5 o'clock on Friday night because they don't want to keep them for the weekend and expect me to look after them, don't even ring me and tell them. That's why I get angry. You know, this is about, they say it's privacy. We don't have the right to tell you that. Well, I say, rubbish.
You're about to say something else there, John. Linda.
Yeah, the carers who knew about things called advanced agreements or advanced directives were very excited by them. And these are
They're not in every jurisdiction, are they?
No, and they're not legally binding. But basically, put into place with the right spirit and the right will of wanting the best for the consumer from all parts, of when a consumer is well, just making a list, an agreement, whereby these things are put into place when they become unwell. And that enables carers to be involved when the consumer is unwell, because quite often when a consumer is unwell, the last person they want involved is their carer. But that's not the real state of affairs, that's just the illness speaking. And that's when often the mental health professionals are listening. So even if they get a negative response in the first place, they should go back and ask the question again and again, can we involve your carer?
And I mean, I think that is important because it's a relationship over time.
Yeah.
So you do have the opportunity to visit this, over some time. But it is that shared understanding of the information that is required and the information that's prepared to be shared. That's a discussion.
Joe, what are the issues if, say, somebody alleges abuse, and that's the carer? I mean, the abuse by the carer has been alleged.
Separate the issue of, certainly that's an issue in itself if there's been abuse, but clearly the argument is that for consumers or people suffering with depression and that they need to be connected with another human being for support. And health professionals are not there 24/7 unless the person's in an institution. But the average person who's suffering with depression and anxiety is living in the community, and therefore there needs to be lessening of that isolation and loneliness. And getting back to your point, John, about privacy, sometimes that becomes an agent again, joining in with the depressive stuff.
And look, I absolutely agree with that.
Yeah.
I mean, I think it's used sometimes because it's easier than having a talk. I absolutely think that that's an issue. On the other hand, there are going to be circumstances where it is important to maintain privacy. It's just very rare.
And the issue of abuse in itself, I mean, that's a really complex issue. You can do a session on that, but certainly a health professional should advocate for that person, because that abuse is going to perpetuate that person's mental illness to deteriorate.
Norman, could I just say that I agree with Chris, there does need to be a discussion, because there are some people, I think a minority, that might fall into that category that you raised the question about, that under no circumstances should they be forced to disclose information. But that can be very easily determined, because those people are normally very clear about who they want a relationship and who they don't want a relationship. But there are those people. But again, it goes back to that discussion. If the discussion's had, then the plan that Linda was talking about can be put in place in terms of, well, it's not legally binding. It's an indication of what would work best while the patient or consumer's in the best space to say, well, I'd be relaxed with this, but I'm not relaxed with that, or whatever. But you can come to an agreement.
And with goodwill.
With goodwill.
And consistency, you can actually get through it. So, Linda, what do you think are the key things that a professional can do to help a carer through this time?
Well, the workshops we listened to, over 1,500 carers all around Australia. And the number one issue was to listen, to hear what they had to say about the consumer's health. One of the most important areas they found was when the consumer is beginning to be unwell again, they know, they live with these people, they have a sense of things starting to go downhill. Now there's no one to whom they can give that information to prevent an acute illness developing. And that's one of the things that they really were finding very difficult. There's no avenue, no venue that they can actually put that information and say, please help.
And be believed.
And be believed.
Let's move on to our second case study, which involves a young carer called Ned. Ned's 17 years old, lives with his mother, Sue. Parents have separated, his father lives in another state. Sue suffers from multiple sclerosis and has psychological issues, obviously a bit of depression, not obviously, but depression and anxiety associated with her condition. She's limited mobility. Ned assists with her care, doing household chores, cooking, cleaning, laundry, assisting with showering his mother, changes her catheter at night if necessary, and he's still going to school, but he hasn't told his teachers of his mother's illness. A hidden carer issue, John?
Yeah, well, Well, I mean, the first thing that would jump out at me from there is the primary health service professional who's providing some care to the mother given her disabled state would need to be asking questions about what is this person's domestic situation, who is actually looking after her, who's providing care for her. Help me, a 17-year-old, how are we providing support to this young person? What are they doing about their school? What I mean, there's got to be a system. What I mean, we can't just have gaps in the system where we can have someone looking after the physical welfare or the psychological welfare of a person and not looking at the whole of life issues.
I mean, Joe, children as carers must be even commoner in the Indigenous community.
It is. Partly because of the way family structures are, as well as the level of burden from a number of areas. For young people, they'll have higher level of responsibility because of the cultural issue of seeing it's an obligation and what you should do. But what goes along with that is their own developmental needs as a young person gets neglected. And
they can be quite young.
Yes, like age 10 onwards, yeah.
What did your groups tell us about young people as carers?
Well, it's very hard to access young carers because they don't see themselves as young carers, they see themselves as part of the family. But, you know, we know of young carers of 5. If they're a single child in a home where there's a mother with mental illness, they're a carer, and they do the job of a carer. It's very hard. There is no structure. There are no structures in place whereby that child is identified at an early age as needing inputs into that family to assist them to cope and help for the child to grow up in as normal an environment as possible with all the opportunities that children have.
What stories did you hear?
Oh, we heard quite a few. And one that is poignant, really. It was an adult speaking who had been a young carer. And this young woman hadn't learnt really the interaction to have a peer group. She'd never really invited children home because it wasn't a place for children to be. And she had so many jobs and responsibilities to do in the evening. She didn't really make friends. She just cared and did what else was necessary. And so as a woman in her 30s, she was finding that, you know, friendships would be nice, but she hadn't gone through that peer friendship stage that children normally do. Very sad.
We're talking about families in poverty here, even though their means might have been considerable at one point. Their salaries are lost, children can't go out and get part-time jobs themselves because they're caring. What did you hear, what do we know about the social welfare payments that might be accessible and the variability in those?
What we heard from carers in general, that the Centrelink forms are totally inadequate when it comes to mental health issues. And to answer the questions is really quite difficult. Now, when it comes to a young carer, that's even harder because...
Can they access carers' payments?
Under 16, I'm not sure on this, but under 16 I would doubt it, even though maybe John knows more?
No, I don't, but I think you're right.
Yeah, and the problem they had with both Centrelink and housing and all those sort of issues that people are concerned with when they're living on low incomes and they're renting houses is being taken seriously, and GPs being taken seriously as the carer when they're standing there as a 12-year-old talking about these serious issues, that they are actually responsible.
And some payments are quite open to the interpretation that you could help the young people, but there's variability in how they're assessed from state to state, place to place.
I think the Centrelink payments are national, so that's sort of the same sort of payment, and they're probably the most common ones. There are 2 carer payments. But access to them for young people, I think, is quite hard.
And FAXIA, the family and
FAXIA provides a lot of services for carers generally. They've put into place respite care for mental health carers, and their guidelines are very, very wide. Their interpretation is fantastic if you look on the FAXIA website. So young carers really can access an awful lot of help through the FAXIA Respite for Mental Health Carers scheme. Help in the house, tuition, things like playing guitar lessons. Something to give them that little bit of extra to recharge their batteries to help them care.
Chris, under the radar for GPs, this one?
Oh look, it is a challenging area. I think rural and remote GPs have got a tremendous advantage because they are normally in a small community, so they do know the services that are available, and they do have very good contacts with community health. So, you know, this is a hugely challenging problem, and a lot of it is about people, you know, coming up with these artificial boundaries that aren't real but absolutely impact on their care. You know, like patients with a mental health can't have a drug and alcohol problem as well because there's two different services that need to address those needs. So you can't send them to one unit, you can't send them to the other unit, there's nowhere where they can go. And these sort of boundaries that are so artificial just make life miserable for carers and for patients.
What to do about the school, Joe?
Could you say that again?
School. I mean, obviously they don't tell the school, or the school, there's bullying that goes on. Bullying apparently is quite common in this group.
I think we're also, with everything that's being said, there clearly needs to be not just health professionals, but professionals in schools advocate, well, their own awareness needs to be raised, but advocating better for greater acceptance of mental health issues and to show greater regard and respect for people in such situations.
But in a small country town, Chris, could use your practice nurses, that sort of advocate?
Absolutely, but I mean, actually, I get a lot of involvement from counsellors at schools, and I actually find them a really helpful part of the team in managing a lot of these issues, because they can often pull a lot of educational resources into the home, and there's a whole lot of stuff that can happen. But absolutely, our practice nurses do a lot, particularly dealing with mental health issues for people with chronic disease. And they've got the skill set that makes a real difference to the quality of life.
Is Headspace useful, do you think, John?
Sorry?
Headspace.
Oh, look, I think Headspace is a magnificent opportunity. Well, I mean, there's only 30 sites at this stage, with some funding just come through for up to another 30. They deal with the very young age of 12 to 26. They're very focused on early intervention. They've got a great website which gives great information for young people. They're also into the new technologies of texting, etc., that young people seem to dwell on so easily. You know, it comes naturally to them. And aside from Headspace, Beyond Blue also have a Youth Beyond Blue website which has a lot of information which gives these people the opportunity to access it. So there are some opportunities for access for these young people. But what I'd go back to previously, I think, is the schools. I mean, I think the Commonwealth Government over years have developed a program called Mind Matters, which is a school that introduces mental health training, if you like, into the secondary education system. Beyond Blue have taken that a bit further and have developed a program both in secondary and in the primary school. And we've now been asked to look at preschool in terms of developing guidelines for that. So the important hook, I think, in all of this is the school. And Chris has rightly recognised that there's tremendous assistance, and I don't want to overload the schools, but they're at the core of this. And if we can bring them in, then I think we can start to get young carers identified as having some challenges in life, and maybe it's through the school that we can get them to the GP and to help.
Certainly the carers that we spoke to, one of the things they really wanted to get across was not to the counsellors. The counsellors were great, they helped tremendously, but it was the ethos in the school. They needed the school principals, not just to understand mental health, but to understand the issues of being a mental health carer, that they might end up late coming to school, that they might have to have their phone on that day, that they might not get their homework done. And these sorts of things can encourage bullying within the school, but also from the school teachers.
So there needs to be an advocacy there, but doesn't it also go to the point that extra help needs to be given to the person with the mental illness or physical illness bringing on the mental illness so that the load on the carer is reduced in this situation so they can develop normally?
Oh yeah, I mean definitely, that's sort of, yeah, goes
Seems
without
like the
saying.
bleeding obvious to
Yeah.
me. But,
Well, it's the old proverbial no-brainer.
right,
Norman,
yeah, but
you know,
Dr. Mitchell's laughing because he knows how hard that is in a rural
Well,
community.
yeah, but you know, it's interesting. You know, they both need help. Is the reality.
Yeah. And the reality is that 1/3 of the people who need some sort of mental health service get it. Now, they either don't get it because the 2/3 don't get it because it's not available, or because they don't feel comfortable about seeking it out because of this dreadful stigma, or because nobody's given them the access point.
Yeah.
So, you know, we need to up the ante on the system, but we also need to up the ante on the access point so that we've got more people pushing in the one direction.
Is there a risk of pathologising here, of making people sick as carers by over-pathologising what is, albeit not a normal situation, but certainly a situation that's part of life for some people, unfortunately? Joe?
I think there is a risk. Well, the fact that it's stigmatised, there's a risk in itself, you know, because people perceive it in a negative light. But if there was more done, which, you know, Beyond Blue is doing fantastic work around raising people's awareness in using different medium. If we talked more about mental health as you do similar to diabetes, people would understand it's a vital organ as other organs that sometimes is struggling and needs medication and other things to happen in life for a person to suffer less.
I mean, I'd argue that a lot of the basics of cognitive behavioural therapy, if you're not suffering from depression, it's a fantastic treatment for resilience anyway.
Yes.
So you know, really, a lot of the skills that we have in terms of treating mild and moderate depression are really applicable just to help people cope with very challenging situations.
Let's go to our final case study, which is another Beyond Blue carer study. Trish, whose husband Rob developed depression after being diagnosed with a chronic illness. Trish describes how she looked after herself during those difficult times.
In the early stages, I don't think I did much to look after myself at all, and I think if it hadn't been for one very special friend, I don't think I would have made it. I didn't go into depression, but I felt a few stages there that I might need to see someone and talk to for myself, but I didn't. It would have been helpful had I. I think my saving thing was that I keep a diary, and I've done that for many, many, many years. I've always kept a diary, but I wished I'd spoken to somebody professional or some organisation. I wished I'd done that. Now, as I look back, I should have, could have, would have. That would have been more helpful than struggling alone. And it was only when I got to know Beyond Blue, saw what they suggested and the helpfulness that they offered, it was only then that I realised I needed to look after myself. That's hard because I like to look after other people, so to look after myself was a little bit of a new thing. I would walk 4 times a week, 5 times a week. And I found that to be very therapeutic, just to be out there on my own, just breathing in the air, and that was time out for me. It took me a while to realise that my attitude needed to change towards Rob. He was sick and I was well and I was wanting to get on with life. I had to really keep in check how I was thinking. My thinking did go bad for a while, and I could feel myself getting very angry. I could feel myself, resenting him being sick, because I still had so much of life I wanted to live. Once I changed my attitude to one of love and understanding and compassion, I found I rekindled something that I'd lost along the way. I'm quite excited at the moment because just this year, for the first time, Rob's doing things he's never done in 15 years, I think, or 13 years maybe. One day our grandchildren came and Rob got the guitar out to play. Now, he hadn't played it for 10 years, and he just couldn't even do Twinkle Little Star. That's how rusty he was with the guitar. But he fumbled his way through it, and that was the first time I thought, gee, he's got this guitar out again. This is exciting. I was excited. You want to say, hey, hang in there with them. You know, it is worth it. They're people of worth. You know, they don't choose to be unwell. They just are. And there's a chance of recovery, and there's still a wonderful life to have together.
Takes me beyond blue. It makes me realize there is hope.
Tricia's story. So a lot of the themes we've been discussing tonight echoed there, Jo.
Yes, especially around guilt and not what part you play in that.
So I want to get down to practical strategies here, things that you can tangibly do. I mean, I've heard the message here, planning, involvement, not getting too worried about privacy, getting the rules right. But let's just get down to practical strategies, because people need comprehensive help for their physical and mental well-being when they're dealing with this sort of situation. What do you think, Linda, from your research and experience?
Well, for our working with the carers at the workshops, it was actually getting down to the nitty-gritty of what made them tick, getting them to look internally and what gave them pleasure, the simple things in life that gave them pleasure, and finding the time and space on a regular basis to do them, whatever the circumstances were. Because without doing those things, and it could be as simple as going for a walk, reconnecting with things that gave them pleasure was one of the most sustaining things that they could do.
We've got a question from a pharmacist in rural New South Wales. Are there any carer support networks in rural areas? Well, first of all, do you know the answer to that question?
No.
And there's not very many. But how important is mutual support to all this?
I think that was the other thing. One of the things that came out from our workshops is at the end of them we asked for an evaluation. What's the most important thing that happened today? And many of the workshops said, I am not alone. They'd met up with a group of people, they could let their hair down, they could be honest about their feelings of frustration and anger and whatever else they felt without feeling they were letting anyone down. That mutual support, that peer support seemed very important, and support groups have started as a result of getting together for those workshops. But that getting together, it might just be a cup of coffee once a fortnight with a group of friends, and that's how some support groups work in the rural places. But somehow to facilitate that is very important to help people cope.
I mean, I think the local network or division is a great place for pharmacists and GPs to call. But CareLink provides a fantastic service and will often be able to hook you into different groups in the area and different support in the area. But just getting back to what do you need to do, what are the practical things, I thought that was a fantastic story about those things, because it's somebody listening, it's increasing your activity, it's scheduling the things that you like, it's reframing, it's some straight thinking, and also it's actually identifying that there are problems that need to be solved and working through those problems. And I think those stories are really what our patients who are carers need to hear as well.
Psychologist in New South Wales, Chris, asks, why shouldn't carers be routinely included in mental health case planning?
Well, I don't have an answer with that. I think they should be included in the case planning.
And then there would just be an issue of the boundaries and rules about that?
Well, yes, you've got to get a shared understanding of the information, but the carers are fundamental to the care of people with any chronic illness, including mental health.
You've got somebody who's got major depression, John, who has harmed themselves in the past. That must strike fear in the hearts of a carer, where they don't want to let this person out of their sight. And therefore, no matter how much you say you can go to the support group, you've got to go out and go have a walk, you've got to cook more healthily, they'll say, I'm sorry, I'm on eternal vigilance here to stop this person harming themselves or even killing themselves. What's the answer? What's the response?
Oh, look, this is the case of tough love, Norman. What I mean, we're all here tonight talking about this issue, and the people out there are listening to us because they want to improve healthcare for people who suffer these various illnesses. If we don't look after the carers, they're going to lose a major resource in terms of helping them to provide the professional care to that. No carer can be 24/7. Let me tell you, we tried as a family because we knew our son was suicidal. But you just can't live their lives for them. And as tough as that might sound, the reality is that they will get under your guard. At some stage you will go to sleep, you'll turn your back, the phone will ring, something will happen, and you will not control it. So you can do everything you can, but at the end of the day, you have to understand that you can't completely manage their lives. And I think the resources that are available today through the Beyond Blue website, there's a family taking care of your family book which deals with all of those issues like grief and anger and suicide and family disturbance, all those sorts of things. Tap into those, tap into the carer book. They tell you you're not alone. And the message for me is listen, hear the message, include the families in the programming and the planning, and make sure they're supported, because they are the resource that's providing the overwhelming amount of service in our community today.
Include them in the care process. Sorry, Linda, you wanted to add?
I think as well with carers, it does take a time after a diagnosis of mental illness. It does take time for that to settle. It can be a year, 2 years before they can really take on board the things they need to about letting go, about taking space. It takes a long time to come to terms with it and reframe their life and get used to the new reality of what their life is.
And Joe, practical strategies in Aboriginal and Torres Strait Islander communities?
Ensuring that people are enjoying their everyday cultural life and revisiting what they need to do to become more connected. Yeah.
Chris, you wanted to add? Sorry.
Oh, look, I think families often really do need permission to take time off, and you need to listen to their concerns about it. But they also actually need permission to take a break and recharge their batteries. And I think that a lot of us, you know, who've been in the game for a few years can tell stories about, by having a break, you're actually going to be there for much longer, because you're not going to be exhausted and you're not going to be burnt out. And I think that's a really important message for us to share.
I think it is, and I think a GP saying that to a carer is a very powerful thing, because they might hear it from their brother or their sister, but for a GP to say it from that position of medical authority, it's time you took a break, you can't carry on like this, might have a lot more impact than a family member.
So thank you all very much indeed. It's been a very informative and moving programme. I hope you find it so. So the messages I've got from this are listen, and when you've got even more time, have some more listening time, and act on it, and involve carers in the care planning, and get into care planning as early as you possibly can, and maintain that relationship. And it is hard in rural areas, but there are resources. Our thanks to Beyond Blue, the National Depression Initiative, for making this programme possible, and for providing the DVD Carers, Stories of Hope and Recovery, which I'm sure is available from Beyond Blue. Thanks to you for taking the time to attend and contribute. And there is more information about this programme and resources available on the Rural Health Education Foundation's website, rhef.com.au. Now don't forget to complete and send in your evaluation forms and to register for CBD points. I'm Norman Swan. I'll see you next time.